The ECG is also known as the EKG. Both of those terminologies stand for the electrocardiograph. In the English language, cardio is spelled with a C. In Germanic, it's spelled with a K. It actually happened to be a German scientist that first invented the ECG or the EKG. So the original name EKG is what was used for a long time before it became, before it was altered to reflect the spelling in the English language. ECGs are an electrical recording of the heart, except that we're not really recording it's not like we're opening the chest and placing these electrodes into the heart muscle. What we're doing instead is we're placing electrodes on the surface of the body, and from those electrodes we are reading, in essence, all of the electrical energy being produced. But as the heart is one of the larger and most significant contributors to the changes in the electrical currents in the heart, in the body, what we actually see is interpreted as the events occurring in the heart. It is important, of course, when you do an ECG that you're lying still. Anybody who's had this done in a hospital setting or at a doctor's office will know that you're asked to lie calmly on the table and relax, and so that's an important thing to recognize. And the reason for that is if you're wiggly, the skeletal muscles will contribute to the overall electrical picture and will make it more difficult to read what's going on in the heart. So let's look at the ECG. Let me first help you identify the different components. If we zoom in here, let's go ahead and we'll just pick the first one here. This is going to be where we're going to start anyway, so we might as well pick it. This P wave, so if we look at this, let me switch colors. We'll kind of follow this along in blue. This flat line here is what we call an isoelectric line. And it means that there's, in essence, no net change to the direction of the electrical current. If there is movement of electrical current, it's canceling each other out to give us this flat isoelectric line. That's an oversimplification, but for our purposes it suffices. Then we see what this is, an upward deflection. And this upward deflection is called our P wave. And what that P wave reflects, if we go back here to look at my little list here, the P wave is reflecting or is telling us that the atria is depolarizing. So as the electrical energy travels through the atrium, through the cardiac muscle of the atrium, this depolarizing wave is measured. It's picked up by these electrodes on the surface of the skin. And so that's what our P wave is. Now then we're followed by another isoelectric line here. And that isoelectric line then leads to a dip here, a downward deflection followed by an upward deflection and then another downward deflection. This is our QRS complex. That QRS complex, going over here again, then represents the ventricle depolarization. So in this case, now we have the cardiac muscles in the ventricle that are depolarizing. And depolarizing means the same as we would expect it to mean from the action potentials. It means that the tissue is becoming more positive. We're having the opening of the voltage-gated calcium channels. We're getting calcium to induce more calcium release, and we're going to get muscle contraction, but not yet. I want to introduce you to an important concept. When we're dealing with the ECG, the electrical events, depolarization, repolarization, they always precede the mechanical events. Always. So now let's go back over here and take a look at this next isoelectric line here, followed by another wave, this upward deflection, and then another isoelectric line. For right now, ignore the highlighted, the pink highlighted box. Going over here, that other depolarizing, or that other deflection, that upward deflection, is what we call ventricle repolarization. And again, the repolarization refers to the fact, in this case, the skeletal muscles, those voltage-gated channels, they're closing. Potassium is leaving the cell. Calcium is being put back into the sarcoplasmic reticulum, or being pumped out of the tissue. And so that's going to be what our T wave represents, is that depolarization. Now let's take a look at this step by step. And we're going to start right here, and just to illustrate our location here, we're actually in this isoelectric line. So that's what we're going to see here, is this isoelectric line. And in this part here, so we've just finished the T wave, we have this flat line here, and this is when the ventricle has repolarized. So we're now at that resting membrane potential, which you might vaguely remember, I hope, is minus 85 millivolts for that cardiac muscle. And so this muscle has returned to its resting potential. And the calcium has been put back into the sarcoplasmic reticulum or pumped into the extracellular fluid. We don't have an appreciable amount of calcium in either the ventricle or the atria. And so when both of these muscles are relaxed, we're in diastole. And so if you refer back to what you know about the cardiac cycle, the ventricle is actively filling up with blood at this point. Then we'll begin this next phase. This is, now if you look at the pink box, that shows you where we are. We're now at the P wave. This is what's happening electrically. And the signal starts, as I'm sure you know, in the sinoatrial node. Now, some things to remember, and these are important things to remember. The sinoatrial node, so we're going to say SA node, if we were to take the heart out of the chest, let's say we rip it out, we're going to put it in some lactate ringer solution, and we're going to keep this heart beating. I'm not sure, and so we're going to make it continue this process. We're going to keep it beating. If we do that, what we're doing is we're effectively removing all parasympathetic and sympathetic nerve fibers from the heart in that case. And so when left to its own devices, removed from any influence by the parasympathetic nervous system or the sympathetic nervous system, the SA node will beat on its own at about 100 beats per minute. Now, of course, we're not ripping hearts out of chests very often, I hope. And so in reality, the SA node is slowed down when we're at rest. It's slowed down by parasympathetic nerve fibers. And so the parasympathetic nervous system, through the release of acetylcholine at the sinoatrial node, causes that sinoatrial node to slow down. It's going to regulate the rhythm of the autorhythmic cell and slow it down, slow that process down. So that's the reality there, is it usually slows it down, and normal resting is about 72 beats per minute. Again, this is a little bit dependent on textbook. It's normal to see an average of 70 beats per minute. And of course, that's highly variable from person to person. My average resting heart rate tends to be a bit higher. Obesity will do that to a person. And so my average is usually closer to 80 beats per minute. Back on track then. So as the SA node depolarizes, what we're going to actually see is this wave of depolarization that spreads first through the internodal pathway, heading to the AV node here. Okay, but it doesn't stay in that internodal pathway. And remember that there's a pathway that takes the signal over to the other side of the heart. Instead, it leaks. And so as you likely know, this leakage is going to allow that electrical signal to pass into the atrial tissue, and the atrial tissue will depolarize, and that's what gives us our P wave. Now, the electrical events precede the mechanical events. Very important. So contraction actually will begin right here. at the end of the P wave, that's when the muscle starts to contract. It doesn't contract during the P wave, it contracts at the end of the P wave. And so if we follow that to this next area right here, what we're seeing is this purple wave is meant to reflect the muscle contraction. And so it will start just like the, I'm going to kind of do it in a darker color here so we can see it. Just like the electrical wave, it's going to start essentially in the top, and it's going to squeeze the blood from the top down to push the blood into the ventricle. And you'll note on this ECG here that all of this is happening, let me kind of, again, it starts after the P wave is over, and it's occurring in that during that isoelectric line until about the dip of the Q wave there. Now the AV node, let's look at the AV node. So we're going to start, now the electrical signal has reached the AV node here. And that AV node also contains pacemaker cells. Now, if I were to just isolate the AV node pacemakers alone, so isolate them from any other part of the heart, the AV node pacemakers would beat, those pacemakers would beat at approximately 60 beats per minute. Now, in reality, the AV node beats a little faster, and the reason for that is that the signal from the SA node essentially triggers or activates the AV node a little bit sooner. There is a bit of a delay, this AV delay that we talked about in the previous section. But with the with the SA node, and the rhythm generated by the SA node, the AV node fires at about the same pace, approximately 72 beats per minute, about so. So that the rhythm of the heart is maintained. Importantly, just like we have sympathetic fibers that run to the SA node and parasympathetic fibers that run to the SA node, we also have parasympathetic and sympathetic fibers in the AV node. And what they can do, among other things, is they can actually increase or decrease that AV nodal delay. And if you imagine in a case of such as exercise, for example, we still want a delay. We want the atria to squish the blood into the ventricle, but then we want the ventricle to contract fairly quickly so that we can get that rhythm of the heart going faster. And so one of the things that happens there is that we're going to decrease the AV node. So now we assume the electrical signal has reached the AV node, and from the AV node, what it does is travel down that bundles of His, as we talked about. So we have this common bundle here, and then of course we have the bundle branches left and right, and that signal will travel down. It doesn't begin to spread into the tissue until we reach those Purkinje fibers. Now, once we're in the Purkinje fibers, the electrical impulses will spread through the muscle tissue, again beginning at the apex and traveling upward through the tissue in such a way that we're going to squeeze the blood out toward the arteries. And so the blood is going to be sent essentially this way to the pulmonary arteries, and essentially this is not a great heart, but anyway, here's the aortic arch up here, and we're going to end up sending the blood onward as such. But not due to the electrical pulses. Remember, the electrical events always precede the mechanical, and so the QRS complex is the electrical event that corresponds to ventricle depolarization. The actual contraction of the muscle won't begin until after that QRS wave has completed. So let's look at that. Here we have the repolarization, the depolarization that triggers that muscle contraction. So the muscle contraction begins after that QRS wave has been completed, and the muscle again is going to contract, and it's going to push that blood up toward the arteries. And that begins here, okay, during this isoelectric line. Actually, in some cases, it'll begin a little sooner. But interestingly enough, it'll actually continue. So if I were to continue to take this box out longer, it will actually continue during the T wave as well. And in fact, if I were to overlay the pressure diagram from the Wigger's diagram to look at just the pressure being generated by the heart, I would have to draw the isoelectric isovolumetric contraction phase here, and then we'd enter ventricular ejection, and we would continue to be in ventricle ejection phase for the most of the T wave before finally entering into that isovolumetric relaxation phase. This is not meant to be textbook perfect. If you go and look at the Wigger's diagram, you'll see a much better relationship there. It's just to give you a general idea of how this contraction overlays with that QRS / T complex there. If you look at this next part, you'll notice that the purple is still there. And that's because now we're in the T wave, and this is basically ventricle ejection. That's what's happening right here. The ventricle is ejecting. Now, while the ventricle continues that ventricle ejection, we're getting to, the latter part of the ventricle ejection phase. What we end up seeing is this repolarization of the ventricle. And so to represent that, I'm actually going to have to cheat and kind of go over here to this, because the white highlighter doesn't show up, and I actually haven't found anything that showed up. So we'll just use this, and we're going to erase it. Okay, so I didn't mean to erase the whole heart, but I don't have a better option. So as we repolarize this, the heart is still contracting, but the repolarizing wave spreads upward. And so we get that. I wonder if, I don't think so, but we'll try. Not really. Kind of. Okay, so we get that repolarizing wave. Maybe if we keep coloring, moving upward like so. Okay, and so that repolarizing wave occurs during the T wave. Again, electrical events precede the mechanical, so the mechanical event of the ventricle actually relaxing, whoa Nelly, that mechanical event won't actually occur until after the T wave is over. And so at this point, the ventricle will begin to relax. And that brings us back full circle. This is when the ventricle, the muscle fibers themselves, relax, and we enter into diastole, and we can begin to feel the heart once again. So that, in a nutshell, is the EKG together with the mechanical events as they work together, so we can actually see all of these events taking place simultaneously. One thing I forgot to mention, let's zero in back here. Once again, if I were to go in here and let's say I were to cut out a little piece, we're going to chop into those Purkinje fibers, and now I'm going to put these Purkinje fibers in a little petri dish, and I'm going to measure them and how often they beat. All by themselves, they will beat, Purkinje fibers will beat at about 30 to 40 beats per minute. And I want you to keep that in mind. 30 to 40 beats per minute, but they don't beat that slow because the signal from the AV node makes sure that they're beating in rhythm to give us a rhythm of about 72 beats per minute. So the lub-dub occurs every 72 beats per minute or so on the average individual. We'll come back to these pacemaker cells and talk about how that affects abnormalities that we might see in the ECG. So this particular part, I don't actually have a slide, and if you want to skip it, you can, but it will help you. to understand the ECG and the electrical events of the heart. So we'll do that next, but feel free to skip that video if you desire.